video and switch to screen share.
That sounds very, very good. Okay, let me do this. And I want to welcome everybody to the last in our preseason lecture series. Tonight, we are very honored to have Mary Vecchi, who is standing in front of the Grand County of Pennsylvania. I'm from Pennsylvania, and I didn't even know it existed. So I've learned something tonight already, and I'm sure Mary's going to let us learn a lot more. I do have to tell you, well, first let me tell you, I'm just gonna say one sentence about Mary because we're already running late. And that is that Mary is one of our doctors. She works out of the Round Valley Clinic, which is just below the hospital, seeing, everything that comes through the door. And she has a special interest in skiing, and she skis often and with her family. And that's how we became connected and how I learned that she was such a good lecturer. Tonight's topic, as you know, is altered mental status. And if you were to ask how important this is, it has become even more important to me, because I'm sad to say that about 5 minutes ago, I got a call from one of my close friends whose wife is confused, and they are on their way to the Park City Hospital to check that out. And so this is a real topic, and I'm going to let Mary take it away from there. As I said in the little thing I wrote, if you have questions, either unmute yourself and shout out or write a chat, and I'll try and, like I always do, gather them at the end or sometime, and we'll ask Mary, and we're all going to learn great things tonight. So without further ado, take it away, Mary.
All right, so I'm going to shut off my video here so that hopefully I'm not messing with our bandwidth, and we'll go from there. So. All right, and then I should be able to. All right, can somebody tell me if you can see my first slide before I
I can see it. It's perfect.
Beautiful. Off we go.
You're in good shape.
So, yes, unfortunately, I'm sorry to hear that that's going on for your friend, but this is something that we see a lot of in many different settings, and altered mental status is a really tough one because it's sometimes difficult to determine how serious it is, and it's often very difficult to determine how serious it is without further workup. So I would say altered mental status, the lecture could probably be titled altered mental status, or it could be anything, or possibly also when it's a ski patrol lecture, give them glucose and ship them. But we will get into kind of what are the things to be aware of and what to be looking out for. And I know your experience and your education levels vary a lot. So I will do my very best to share what I think is most pertinent, but also please feel free to unmute and speak up, or to let me know if you're having any questions or any concerns or issues, or if I'm talking about something that you guys are just like not able to do in the field, and we can talk about how we could do it differently. So just shout it out. All right, so objectives of the lecture, we're going to go through a little bit of anatomy and physiology. And then we're going to go through your acronym, the AEIOU tips, that use an easy way to just kind of remember those things that are most likely to cause altered mental status when you're in the field. We'll go through some stuff about diabetes, and I think this is a particularly important one and becoming more important, unfortunately, all the time, even in our very active community of people. Just to understand, because altered mental status is one of those scary things that can quickly cause a lot of damage if it's because of diabetes, and particularly if it's because of low blood sugar. We'll talk about the different types of seizures and elements of treatment for that, a couple kinds of stroke, which if you were around last year for my lecture, you had a whole lecture on stroke, so we won't get into too much detail there, but just kind of what things to look out for. The most important thing there is just you need to ship them because we need to get them out quickly for definitive care. We'll talk about how to assess and treat a little bit. Like I said, in the field, things that you can do in that moment that could save somebody's life. And then we'll go through a couple of case examples throughout. So altered mental status, to define it, it's not a specific diagnosis, it's not a disease, but it's just describing what is generally going on. It's a malfunction in the nervous system, and the treatment really completely depends on what's causing it. And the problem with altered mental status is the causes are myriad. It can be so many different things. But I also think when you're thinking about AMS, be thinking almost anything, because while there are those couple of things that are really important that come to the top of your mind, the truth is that there are so many different things that can lead to it. I think in some ways it would be easier to do a lecture on what can't cause mental status, because the truth changes, because the truth is there's not much. Yes, so this generally has to do with the central nervous system, although sometimes can have to do with the peripheral nervous system, but most of the time we're dealing with brain. So here's our first case. You're in the lodge. The manager's calling for help. They found a customer on the floor, really out of it, in the bathroom. So you come up and you let them know you're a patroller and offer your help. You're thinking this might be altered mental status. Middle-aged man lying on the floor. He's confused. He's responding only when you're yelling at him. His radial pulse, you check it. It's fast and strong. He's cool to the touch. His skin is pale. He's sweating. So what do? First of all, of course, for all of you woofers and EMTs, you know you have to make sure the scene is safe. Probably the bathroom floor is fairly safe. You want to make sure that he's, in a safe position. And right away, you want to call for help. You want to let somebody else know what's going on, because yes, this could be something small, but with altered mental status, most of the time we're going to need to ship him out and get him to definitive care. So introduce yourself, ask if it's okay to help. Start performing your secondary assessment, looking for any injuries, any signs or symptoms that might give you clues to what's going on. So getting into anatomy and physiology. So central nervous system, that's your brain and your spinal cord. There are three parts. The brain, which is protected by the skull, and the CSF is made of the brain stem. That's sort of your lizard brain, right? That's breathing, swallowing, responsiveness. Then there's the cerebellum, that's more balance and coordination. And then the cerebrum, that's up high, that's, your speech and your emotion. And any one of these can cause damage to any one of these, or changes in the physiology in any one of these can cause altered mental status. Then there's also the spinal cord, that's the peripheral nervous system and how that connects to the brain. Less likely to cause alterations in mental status, certainly can cause major issues as far as paralysis, et cetera, but much less likely to be involved in mental status changes. And then there's the peripheral nervous system. That's basically everything else. That's all the nerves that connect to the extremities into the spinal cord and brain. So another physiology thing to sort of be at least aware of when we're dealing with altered mental status is responsible for regulating glucose levels that are available to the peripheral and central nervous system via the pancreas, primarily. So the organs of the endocrine system produce and secrete hormones, and including insulin, glucagon, and this is really what in your body regulates glucose levels. Too high or too low blood glucose can change your level of awareness and responsiveness. Although I will say the key thing to remember about this, and I will say this several times throughout the lecture, is the big scary thing is too low. If you give a person with high glucose more sugar, you are very unlikely to harm them. If you give a person with low blood glucose sugar, you may save their life. So the function can be global, right? The change in mental status can be affecting everything equally. You can have, decreased sense of touch. You can have, minimally responsive to stimulation across the board, or sometimes you can have one area of the body affected. This tends to be more what we see if somebody has a stroke, where, they have one side of their body that's more affected than another. So this is where we get into all of the causes. And it's really important to be aware of kind of what you think you're dealing with. But I also really want you to focus on the fact that you could be wrong. So much of the time in medicine, we get pegged into this hole of thinking that something is one thing, and then we go down a whole pathway of testing and treatment, and we forget when it's not working to go back and look at our original diagnosis. And so while it's important to understand what these things are and what they could be causing, it's also important to know that sometimes it's more than one thing, especially when we're getting into this first one. It can be multiple causes for altered mental status. So your A stands for alcohol. As many of you are aware, there are definitely folks out there on the mountain who are intoxicated. It's the most commonly abused drug in the US, and it is a CNS depressant, which means that too much of it can make you altered. And I'm sure that most of us have experienced an individual in work or otherwise who has been under the influence of alcohol, so you know a little bit what to expect. The other thing to be aware of, though, is that a lot of the time, even if someone is under the influence of alcohol, that doesn't necessarily mean they're not also having one of these other problems. So we have to be careful not to chalk it up to alcohol use. Heavy alcohol use can certainly cause altered mental status, but a lot of the time it might be something else as well. So don't assume that, somebody had a beer with their burger at lunch and that's what's causing altered mental status. Get curious and be sure it's not something more. Acidosis, so that's a change in the body's pH, a decrease, which affects homeostasis, and so many different things can cause this. And this is one that you are not going to diagnose in the field. It's important to know that this is something that can cause altered mental status, but you're not going to be aware of this. This is something that we're going to find out once you bring them into the hospital setting. So E is for epilepsy, environment, and electrolytes. So epilepsy is a brain disorder that results in sudden and recurrent seizures. And we'll get into seizure a little bit more later in the lecture. The next one here, environment. Obviously, there can be pretty significant changes from the environment when we're anywhere out in the wild. And this can be from lots of different things. This can be from exposure due to cold or to heat, but can also be from things like bites and stings. Less likely to see that on the ski hill, but I know some of you do some things elsewhere, so that's something to remember. Also electrolytes. So these are all those molecules that help maintain homeostasis in the body. They can be affected by diet and exercise, medications, overall health, increase in sweating, vomiting or diarrhea. Changes in electrolytes are pretty common when people come to altitude, but also with intense exercise. So it's sort of the perfect storm when somebody comes for their once every 2 year ski trip and is spending 6 hours a day on the mountain. Okay, so insulin, we've touched on this a few times already. It's so important it gets its own eye. So any condition that can adversely affect the production or use of insulin and the regulation of blood glucose is something that we need to be very aware of. Often people who have diabetes will be wearing a medical bracelet or be wearing something that alerts you. So look for this on everyone, especially if they're so altered they can't give you a good history, because it's a really important thing to know. And we'll get into a little bit what I would recommend for treatment on the hill. Oxygen and overdose, both of these are important. Any change in cerebral oxygen levels will result in a change in CNS function and an altered mental status. This is the #1 cause of AMS, and it can happen for lots of different reasons. It can happen because you are having some sort of lung dysfunction. And so even a small amount in the oxygen that's available in the air, like at altitude, if you have a lung disease, can cause you to have low O2. This can happen because you're having a heart attack and your blood's not pumping appropriately. But this is why we pop oxygen on people with altered mental status, because again, the likelihood that oxygen is going to hurt somebody super low, and it may save somebody's life, because especially around here we don't have a lot of oxygen that's just floating around. So overdose, this is another one that you may or may not know in the field, and you guys don't give anti-narcotic medications in the field, so probably not going to be that relevant to you on the mountain, but absolutely can affect somebody's mental status. Another one that you're not going to know for sure, but uremia. This is poor kidney function, results in basically a buildup of the waste products of metabolism, and that can lead to lethargy, coma, and ultimately death. So this is a ship or die situation. And hopefully if somebody has had gradually worsening kidney function, they're aware of it and under somebody's care already. But this is something that you wouldn't know about until we got initial lab results back. So T, trauma and tumors, TIA, and thirst. So trauma. Traumatic brain injury, of course, can cause brain swelling, increased intracranial pressure, and then result in either focal or global alteration in mental status. So this is just something to be aware of too. Sometimes you'll be at a scene and you'll know somebody hit their head. I mean, sometimes they're so altered that they're unconscious. And that's a particular situation that obviously you handle a little bit differently. But it's also something to be aware of because sometimes somebody will have what they think is a minor incident, or there are certain types of head injuries where you may be aware of this, that the people will actually hit their head and sort of be fine, but gradually develop this a bleed and later on be altered because of it, because of a developing intracranial pressure. So this is something to be aware of and be asking about. If somebody had a fall, if somebody hit their head, even if they seem like they're fine, they really, you need to take it very seriously, because somebody can, a couple of hours later have a really bad outcome if we don't identify this right away. Just remember that an injury could always have been prior to the scene. The other thing with trauma is sometimes it's brain injury, but people can also be altered from other types of injury, things like femur fracture. I mean, you can even have an embolism from a femur fracture that's causing stroke-like symptoms. So all kinds of trauma, if somebody's altered with trauma, just take that very, very seriously. So tumors, again, this is probably not something you're going to know about. Sometimes the patient will know about it and they can tell you, oh yeah, I've got this going on. Whatever, I'm on this ski trip as a, to celebrate whatever, completing my post-surgical recovery, whatever. I mean, this is not something, again, you're going to probably know about in the field, but certainly we see this as a cause of altered mental status. TIA. So again, if you were in my lecture last year, we went over this a lot. This is sort of, it falls into the same category as stroke, but it's not considered a stroke. Sometimes people call it a mini stroke. But when people have a temporary interruption of blood flow to the brain, they can exhibit stroke-like symptoms, but that lasts less than 24 hours. This is an important thing to investigate anyway. If you have stroke-like symptoms, I don't care if they got better. Somebody needs to come and see one of us docs. They need to follow up. They need to be taken seriously, because even TIA symptoms are serious, because they often are a precursor to a stroke, to something more serious. So they really need to be worked up more. And then significant thirst, T is also for thirst. Significant dehydration can cause altered mental status via the pathway we discussed earlier with electrolytes, but also just dehydration itself can cause this. And we know that people like to come here and hang out at high altitude where we get dehydrated anyway. And on top of that, go out and party too much. And then on top of that, spend 6 hours skiing. So this can surely happen. All right, second I is for infection. So infection that leads to sepsis. That's where the infection spread throughout the body, usually via the blood. Can be associated with altered mental status. If somebody is febrile and has altered mental status, get them out, get them out, get them out. This is not a good sign. This is usually an advanced and grave sign of infection. So definitely get them taken care of as soon as possible. P is for poisoning and for psychiatric causes. So poisoning can be from a substance that was taken on purpose. It can be from something that was not taken on purpose. It could have been intentional that they're poisoned. It could also be unintentional. Just something to be aware of, something to look out for. Again, something you're not going to be able to fix, something that we really usually have to deal with in the hospital. As far as psychiatric causes go, sometimes you'll be a little bit more aware of this. But it could be a patient who simply has dementia, and you might not realize that this is their baseline. And psychiatric causes is one of those where I cannot stress enough with altered mental status how helpful it can be to have collateral information. And we'll talk about this in a minute, but if there's a bystander, if there's a family member, if there's a friend who's around and somebody's altered, they are such a helpful piece of the puzzle, because they may have a better idea of what's going on than the patient does in that moment, and they may be able to give you information that could be life-saving for the patient. So definitely look for that bystander who is appears to be particularly concerned about your patient. That's the person to be asking, hey, are you this person's friend? Are you their family member? And get the story from them. Okay, S is for seizure, stroke, shock, syncope, and sleep. So seizure, as we talked about before, when we talked about epilepsy, but this is an electrical disturbance in the brain, and we're going to get into this a little bit more later, but this is certainly something that when you're seeing an actual seizure happening, it's very clear that that's the cause of altered mental status, but I want you to also be thinking about the stages before and after that tonic-clonic stage that we're also familiar with, because those are times when if somebody has a seizure disorder, they can be altered as well. Stroke, this is that lack of blood flow to the brain, and we're going to go through the signs and symptoms that should clue you in that stroke may be what's going on. Shock, so this is one where yes, a septic shock, like we talked about, can result in it, but also blood loss can cause altered mental status, and even when somebody has an injury without significant blood loss, they can go into shock and have altered mental status from that. Syncope, that's fainting. Always just consider transport. This is something that can be cardiac in origin. Sometimes somebody's just, there's nothing more serious going on, but sometimes it's because of an arrhythmia. And so we have to take that seriously as well and make sure that we get, that we get an EKG on them and make sure that there's not something more serious going on. And then sleep, even minor sleep deprivation can decrease reaction time, can change memory, and can cause irritability. So sometimes it's from all those late nights. So again, I'm going to mention medical alert tags. A lot of people who have conditions like diabetes or seizure conditions will wear a medical alert tag, especially when they're exercising. So definitely look for these bracelets and necklaces to help you figure out what's going on. So diabetes, like we talked about, this is very, very important to be aware of as a possible cause of altered mental status, because it can be deadly and it's easy to treat. As long as the person is conscious, you want to give them glucose. So seizure. So we talked about this can cause altered awareness, changes in attentiveness, responsiveness, behavior. It can cause strange body movements. It can last seconds to hours. But the average seizure, the tonic-clonic phase of the seizure, is 1 to 3 minutes. So know that most of the time, you are not going to be dealing with the actual tonic-clonic phase of a seizure for more than 1 to 3 minutes. Like I said, they can remain altered before or after, but usually that scary phase will pass. If somebody is seizing for 30 minutes or more, that's called status epilepticus. That is a medical emergency. But hopefully if somebody's having a seizure, you're handling and planning to ship anyway. And then stroke. So that's the other one that's medical condition that's really strongly associated with altered mental status. So getting into seizures a little more, they're 2 different major sort of categories of seizure. There's partial and generalized. So seizures can happen in a focal area, including changes in sensation, and also something called an absence seizure, which usually just has sort of a mental status change only. Most of the time people are aware when they have a seizure disorder, but sometimes it's a person's first seizure. And seizures can also happen from, again, changes in alcohol use, diet, exercise, changes in electrolytes. So it's just an important thing to be aware of, that they may not have a seizure disorder, or it could be their first seizure. Generalized seizure, this is the one that, is the scary one that looks most frightening. This is usually both sides of the body. The brain activity will sometimes start in one area of the brain and then generalizes and causes a grand mal seizure. So this is the most common type of generalized seizure. It usually has the tonic activity first. So that's where you see somebody sort of tightening and contracting all over. Often they'll bring their arms in close to their body, and then usually results in the clonic activity, which is that spasming, violently jerking. There are usually these 3 phases. So altered mental status can occur in all of the phases. So pre-ictal, so often someone who has a seizure disorder has what we call an aura, or a premonition of that seizure, where they're aware that it's going to happen before they have the seizure. So a lot of the time you might be with someone or around someone who's telling you, I'm going to have a seizure, and they usually try to get themselves into a place where they're going to be, not falling, not hitting their head, where there isn't anything they're going to knock into around them, because they know that that's going to be the danger of that ictal phase. That is that tonic clonic phase. They are usually unconscious with a grand mal seizure. They'll be unconscious during that ictal phase. And then post-ictal, they tend to be really minimally responsive. And so it's an important thing to know if they've just had a seizure, that you shouldn't expect that they're going to be responsive right away. They're usually pretty out of it for a while. So yeah, status epilepticus, we talked about. This is a true medical emergency. The other thing to be aware of is that sometimes bystanders will think that they saw someone have a seizure. And when you're evaluating reports of a seizure, I just want you to be conscious and aware that sometimes you're going to be seeing effects of another condition. While it may have been a seizure, lay persons are not always the best at identifying whether or not something is a seizure. And so just, again, always be curious, and don't just assume that that's what's going on. All right, so getting into diabetes. My favorite topic. I've treated a lot of diabetes. I do a lot of that. And this is one where, as somebody on the Hill, recognizing that this is what is going on, this is where you could really save somebody's life. So it is that inability to regulate blood sugar level, which can be due to multiple types and multiple reasons. Usually the problem is that you're going to see that they're low. You can definitely have high, but usually it's because they're low. It is chronic, and it can be because the pancreas cannot produce enough insulin, or any insulin. This is usually more of a type 1 picture, or the cells are not responding to insulin. This is more of a type 2 picture. Or it can be both. And a lot of the time, people who develop type 2, then eventually the pancreas burns out and they move more into a sort of a type 1 picture. So glucose doesn't enter the cells, it builds up in the bloodstream, and then that increased glucose in the bloodstream causes symptoms. So polyuria, so that's increased urination; polydipsia, that's increased thirst; increased appetite; changes in weight; also fatigue, dry mouth; and overall, one of the big ones that we see long-term is cellular damage. And that happens over time. So type 1 is caused by autoimmune disease. We usually see it present in the young. Tends to be people age 30 and younger. Sometimes it's little kids, but sometimes it's 20 somethings. And basically the body attacks the pancreatic cells that produce insulin, and so they no longer have insulin available, and so they will have usually injectables or a pump. Most type 1 diabetics eventually use a pump, but this is one of those things that you need to be aware of, because somebody is hypoglycemic. You need to locate that pump and stop the insulin. So it's really easy to do. If somebody has a pump, you'll see there's usually like a little, it looks like a little wire. It's actually a very, very small cannula. And then there's a small needle that's underneath the skin. Yeah, if you are suspecting that somebody is hypoglycemic and they have an insulin pump on, you could save their life by pulling that line out. So type 2 diabetics, unknown cause, definitely seem to see it more in individuals who are obese. There's also likely some genetic predisposition. We are seeing more and more of this in the community, and their cells tend to be resistant to the action of insulin due to overproduction of insulin, usually due to high levels of sugar in their diet, and also probably genetic factors, often likely both. Which is controlled by weight loss, exercise, and then also medications to help reduce glucose levels. So sometimes individuals who are type 2 are also on insulin, usually not a pump. They usually use injectables 3 or 4 times a day, but usually start out just on oral medications. And then there's also gestational diabetes. This is diabetes with pregnancy. I don't see as many pregnant folks on the ski hill, although occasionally you do. So we're going to go through basically hypoglycemia, hyperglycemia, and what you would expect to see, and may notice symptom-wise, and then a little bit about, kind of what to do. So hypoglycemia, or low blood sugar, usually blood sugars less than 70 are where people will be symptomatic, although sometimes individuals with diabetes will be symptomatic at higher blood glucose levels as well. This usually happens when someone either takes too much of their medication, or they take their medication and they don't eat adequately or exercise a lot. So this is why in a setting where people are being very active, it's really important to understand that this can happen, because sometimes people didn't take too much of their medication, they're eating, but they're just exercising more than they're used to, and that's enough to throw them into a hypoglycemic episode. Typically early on, they'll feel a little dizzy, they may be a little tachycardic, sweaty, feel kind of anxious, sometimes they'll be shaky, have a headache. Then that leads into that altered mental status, confusion. As long as they are conscious and they are able to swallow, this is the time to treat them with oral glucose. And my understanding is, I talked to Allie today, and she said that I think you guys carry tubes of glucose in your packs. If they are safe to swallow, if they are talking to you, if this is, give them glucose, just give it to them. After glucose, this will usually resolve really quickly and they'll start feeling better right away. As things get more severe, they can be more confused, more disoriented, they can become lethargic, they can start to slur their speech, they can even have seizures, end up with signs and symptoms that look like stroke, be completely and unresponsive or really combative. So don't assume if somebody's slurring their speech and combative that they are drunk. They may just be hypoglycemic. And you're not going to hurt a drunk person with some glucose, but if you can get a hypoglycemic diabetic to take some glucose, again, you may save their life. And if you don't have your pack, or you're thinking that this is going on somewhere and you don't have access to a tube of glucose, you can mix 4 or 5 sugar packets into a cup of water and have somebody drink it, and that will do the trick. So that's not a bad thing to, carry as well, if you don't have access to a tube of glucose. So hyperglycemia, increased blood sugar, it's defined as blood sugar greater than 180, although typically, especially in type 2 diabetics, you won't see many mental effects until somebody is way up there, usually greater than 500, sometimes even greater than 700, 800, or 1,000. So this often happens if somebody forgot to take their medication. They will usually be peeing all the time, really, really thirsty, dry mouth, feel fatigued. It can increase to nausea, vomiting, altered mental status. It's unusual to encounter this in a recreational outdoor environment. Because people are being active, and that's part of skiing, you're much less likely to see this. And the main thing I want you to take away from this is that even if somebody is already hyperglycemic, you with a load of glucose are not going to hurt them. Their blood glucose level is not going to go up enough for you to cause major damage by treating them with sugar. So if you're looking at this and going, wait a second, hypoglycemia and hyperglycemia, they kind of look similar. They could come to me and look basically the same in either situation. If they're diabetic, assume it's number 1, and you're not going to kill them if you give them glucose. All right, stroke. So this is that neurological impairment due to lack of blood flow. There are 3 major types. So that's ischemic, which is the most common. 80% of strokes are ischemic. This usually results from an embolism, which can happen from different things. It can happen from a blood clot, but as I mentioned earlier, it can also happen from fat, from a major fracture. So like a long bone fracture can cause this. And it also can happen from plaque migration from individuals who have high cholesterol. So the second type, hemorrhagic, this is from a blood vessel rupture. This tends to be much more dramatic. as far as symptoms, and also as far as failure of recovery afterwards. May result in something that looks a lot less like the stroke symptoms that we're going to talk about, and a lot more like unconscious. Um, but certainly this is something you just got to ship as soon as you can. And then TIA. So this is not technically a true stroke, but is often a precursor to a true stroke. So we need to take it very seriously. Temporary interruption in blood flow. No permanent brain damage from a TIA, but can certainly mean that a bigger event is coming. Symptoms have to resolve within 24 hours, and it can be an early warning sign, so just take it seriously. So this is that famous AHA picture of kind of that one-sided facial droop, which is certainly one of the signs to look for. If you see someone with a one-sided facial droop, you are not to diagnose Bell's palsy. Yes, Bell's palsy can also cause that, but you need to get somebody shipped right away, unless they are telling you, no, my face has been like this for a long time. I had a stroke before, or I have Bell's palsy. It's already been diagnosed. Otherwise, take it seriously, ship them. So other things that can be signs or symptoms of stroke, altered mental status, which is why we're talking about it. Also headache, this one side of the face droop, which we talked about. Also paralysis or weakness on one or both sides of the body. Loss of bowel or bladder control can be a sign of a stroke. Personality changes. So sometimes that combativeness or sort of failure to follow instructions can actually be a sign of a stroke. It's not the most common thing that we see, but it certainly does happen, and we do see it fairly often. Unequal pupils, can be a sign of stroke or head injury. Always take that seriously. Loss of vision, dimness in vision, double vision, all can be stroke. Inability to speak or changes in how the speech sounds, absolutely often a sign of stroke. Nausea and vomiting can be a sign of stroke. Sudden weakness, paralysis, or seizures. All right, so back to our case. You asked for their permission to help while you're doing your secondary survey. The man's eyes roll back in his head, he groans, he stiffens, he begins to shake violently. What do you do? So number one, protect his head. You want to clear objects from the patient's airway, and please do not let anyone put something in a seizing patient's mouth. Sometimes people think that we need to protect them from biting their tongue. They may bite their tongue. That can happen. We stitch this up when they come in, but we definitely do not want to put anything in the mouth, because the seizing activity could cause something to become dislodged and could compromise their airway, and this is not good. Very unlikely they're going to bite their tongue off so much that they compromise their airway with a piece of their tongue. Keep things out of their mouth and keep things away. Time the seizure. So if somebody starts seizing, look at your watch. You want to see how long it's lasting. Remember, 1 to 3 minutes is pretty average. More than 10 minutes is absolutely a medical emergency, but you should be thinking about shipping them and calling for help right from the very beginning. Fortunately, you were smart and you called for help as soon as you saw altered mental status. So after a seizure, place on the left side and make sure that the airway is clear. Again, they can be quite altered, and these patients can sometimes struggle to protect their own airway, but do not put anything in their mouth. Just turn them on their side, make sure that their airway is staying clear. Check for their wallet or a medical bracelet to see if they have a seizure disorder. So you check the bracelet and the patient's diabetic. Now what do you do? If they're conscious and they've come to and able to swallow, give sugar. Absolutely, hypoglycemia in a diabetic can cause a seizure. So don't assume that it's epilepsy. It could be diabetes, and they could just be hypoglycemic. And then you're going to continue to monitor ABCDs while you get them to definitive care. So this is the other place where, as we talked about, I want you to gather family and friends or bystanders. Sometimes somebody has a medic bracelet on, but sometimes they don't. And sometimes their friend will be able to say, oh yeah, he was just diagnosed with diabetes and they've been working to adjust his medication regimen. Okay, that's a huge piece of information. And if somebody was just diagnosed, they may not have a medic bracelet yet. Also, their friend might be like, yeah, we were skiing through the trees earlier and he hit his head, but we didn't think it was a big deal. This is a very big deal. If they are now altered, this is a huge deal, and you need to get them to the hospital as soon as possible. They may need to have brain surgery in order to fix it. So definitely ask for bystanders, gather family and friends, think about pulling out their phone if they have their phone in their pocket and looking for that emergency contact. All of these things can be helpful in order to figure out what's going on. So do your primary survey, of course, do your ABCDs. I don't think you guys really use Glasgow Coma Scale. Some of you might be familiar with that, and that's certainly fine. And when you're talking to EMS or the hospital, that can be helpful. But just remember the AVPU, alert, verbal, pain, unresponsive, right? So alert oriented, they're answering your questions, they're doing fine. Verbal means that they're talking, but maybe not so well, not making a whole lot of sense. Pain, that means that they're not talking to you, but if you pinch their finger or that you do a sternal rub, that they're responsive to painful stimulus, they pull away. And then if you are pinching a fingernail or sternal rubbing and they are not responding, that is a very important thing for us to know. So that is your U. So be looking for clues. Hypoxia and hypoglycemia are the two most common causes. They are easy to treat and they are unlikely to harm. So give them O2, give them glucose. If they are conscious and able to swallow, give them glucose and get that oxygen on them as soon as you have it. And then of course, just activate EMS. You want to get help for somebody who's altered as soon as possible. So secondary survey, take your history, get your vital signs. A lot of this stuff is going to be really helpful to the team that arrives to transport to definitive care. Again, gather as much history as you can from others, ask the patient or others about medications, especially if they may or may not be traveling with EMS. That's a really helpful thing for EMS in the hospital to have when somebody's a visitor. We may not have access to that information right away, so that's very, very helpful. So do pupillary exam, do motor sensory exam, look for higher cortical function exam, look for alterations that could be an indication of what's going on, and definitely doing that vocal and speech exam. That can be a signal of something more serious going on. Continue to monitor ABCDs. That's always going to be your most important thing. Do that oxygen, do that sugar. Consider spinal precautions. So this is something that if you're finding someone down, generally just assume that they've got a spine injury until, if they're not moving and you find them in any sort of a position on the hill that is concerning and they're unconscious, you want to assume until they are cleared that there is something going on with their spine. And yeah, load and go. So we're going to go through the AEIOU tips again, just kind of talking through what to do for each thing. This is pretty quick because a lot of it is the same, but just to remind you of what that acronym stands for, and then give you again the things that you can do that can be supportive in order to get them to safety. So alcohol and acidosis, both of these are going to protect the airway. Of course, we're always doing that. Make sure you're supporting respirations and rapid transport. For epilepsy, environment and electrolytes. So remember, protect from injury, protect their airway. If they are in an environment where they're at cold exposure, which often our folks on the ski hill are, try to do things to keep their body temperature normal or restore a normal body temperature. And again, rapid transport. So insulin, give sugar. As long as they're conscious and can swallow, give sugar, give sugar, give sugar, give sugar, and then activate EMS, monitor and transport. Oxygen and overdose. So watch those ABCDs. Our folks who are hypoxic and who are overdosing are likely to lose one or more of these things. Give them O2, transport. Uremia, again, you're probably not going to know this is what it is. If you think that's what's going on, I mean, it's ABCDs and transport. This is really transport diagnosis. Trauma, so TIA and tumors, you're going to maintain ABCDs, you're going to give them high flow oxygen, you're going to treat to prevent shock as much as you can. So in a case of trauma and altered mental status from trauma, you want to make sure that you are hopefully maintaining as much as you can, which includes both, keeping them warm, but also making sure that you're stopping any bleeding, all of your normal trauma stuff, and then transport as soon as possible. For infection, if you're remote, consider cleaning a wound. This is, again, this is not so much of on the hill thing as it is for those of you that do guiding and things elsewhere. But think about cleaning a wound. If you have a trauma and you're concerned about infection, you can cool fevers. Again, this is probably not something you're going to do on the hill, but you can give somebody an NSAID and help with that when you're out in the field as you are getting them to definitive care. Infection is ultimately usually going to require antibiotics. Poisoning, psychiatric, ABCDs, O2. If you think that it may be a poisoning, contact poison control, get that case started, because depending on what's going on or what you think they may have been poisoned with, it can be really helpful for poison control to have that information and start their research on what should be done. And it definitely helps us out in the hospital setting if we have already started the conversation with poison control ahead of arrival. And then for psychosis, support, prevent from harming self, transport. Seizure, stroke, and syncope. Remember, prevent further injury, just like with epilepsy. Seizures, you want to make sure that they're in a situation where hopefully they're not going to hit their head on something, hit their body on something when they're in that tonic-clonic phase. Maintain airway, ABCDs, high flow O2, and then activate EMS and transport. So this is something that we should just touch on, and your textbook definitely touches on this, violent behavior and altered mental status. So this is not uncommon when someone is altered, and this can be really for any reason. It's not specific to any one thing, but altered mental status can cause people to be violent and uncooperative. Things to remember, this can be super frustrating. I've dealt with this a lot, and I know it can be very, very frustrating when you're just trying to help somebody and they are not having it. But try to remember and be aware that they are usually completely unaware that what they're doing is not appropriate. And just try to continue to provide support where you can. It can be very difficult because you can't reason with them. When someone is altered, they can't listen to reason. So as much as you might try, it may actually frustrate them more. The best thing is to be calm and as reassuring as possible and continue to do your work. Monitoring all of those things that we need to monitor, offering them supportive measures that may be helpful, try to be their advocate, and meet violent behavior with, of course, support as needed. But ideally avoiding use of force. Usually this will just cause harm. Of course, there are situations where somebody's going to cause harm to others or to you, and you need to be conscientious of that. But yeah, just be aware that patients who are altered can become violent, and it's a particularly tough thing to deal with. But just do your best, continue to provide the best care that you can in those circumstances. All right, so he becomes responsive after you give him glucose. He tells you his name. You give him some sugar water, yep, and you monitor him. Within a couple of minutes, he's fully oriented. Yes, it really does happen that fast. If you haven't seen this happen, you give somebody some sugar when they're altered because of hypoglycemia, and they are usually right back at it. And he reports, oh, he was in a hurry and he didn't eat and he took his medicine and then he didn't go, and then he went skiing. So ambulance arrives, hand it off, patient thanks you. Hopefully he's a nice guy and he says, thank you. All right, another case. So you and a fellow patroller riding up the lift when you notice someone lying in the snow face down in an odd body position. Hopefully not really like that. If somebody's lying like that unconscious, please, final precautions. Upon arriving at the scene, you get there and the individual's then sitting up, appears really confused, responding to verbal stimuli, but maybe not making a whole lot of sense. Pulse is fast and strong, skin pale and cool, she's short breath. Acquaintance is on the scene, doesn't know anything about medical history. They were partying last night, they were drinking too much. Friend says she's been going to the bathroom a lot, denies any falls, denies any injuries. What do? You suspect hypoglycemia. So you give them 3 packs of glucose or you use your glucose tube, but she doesn't get better. Fortunately, you called for help. ALS arrives for transport, vital signs stable, she's transported. Later, you find out when she returns to thank you, her blood glucose was 570. She didn't know she was diabetic. She hadn't been diagnosed yet. The reason why I did this case as well is because, as you might recognize, this person looks the same. So just remember, you're not going to harm them with the sugar. Don't be afraid to give it. This person may have had a blood glucose of, 40, and you made it 570. At this stage in the game, that is not a game changer. That is not going to hurt anybody. Just give them the glucose, and you were not wrong for doing it, and she will still be fine. We will take care of that high blood glucose gradually when she comes to the hospital. All right, so these are a couple questions from your textbook. Your patient is in the ictal phase of a grand mal seizure. Your care should focus on A, placing a tongue blade in the patient's mouth to prevent from choking, B, protecting the patient from injury, C, restraining the patient, D, stopping the seizure. And hopefully everybody knows it's B. So remember, nothing in the mouth. Please don't restrain a seizing patient. So you want to clear the area. You want to, maybe hold something so that they're not slamming their head if they're on a concrete floor or something. But you don't want to restrain the patient. You can actually cause more injury doing that. And you unfortunately cannot stop the seizure in the field. But also usually, even a hospital setting, we often, unless somebody's seizing for beyond that 10-minute period, we often will just wait it out. It will stop usually within 1 to 3 minutes. All right, a condition in which there is a temporary interruption of blood flow to an area of the brain resulting in no permanent brain injury is called A, generalized seizure, B, hemorrhagic stroke, C, partial seizure, D, transient ischemic attack. That is D, TIA. So like a mini stroke. Your patient presents with altered mental status. He has a weak rapid pulse, warm dry skin, deep rapid respirations, and a fruity odor to his breath. He has a medical alert bracelet indicating that he is a diabetic. His friend tells you he has not been feeling well for about a week. These findings lead you to believe he is suffering from, and this is interesting. So this is A is hyperglycemia, B hypoglycemia, C epilepsy, D uremia. And this is hyperglycemia. So if you guys are taking your tests and you see fruity odor to his breath or her breath, that fruity odor is usually DKA. And so this is one of those things that when you've seen it or you've smelled it, then you kind of know what it is from that point forward. If you haven't, you won't necessarily know it. But if you notice that their breath smells kind of sweet and fruity, usually that's actually hyperglycemia. But again, don't worry. This is not the diagnosis for you to make in a diabetic. Again, you're not going to hurt them with sugar, but just to kind of know that everything else looks the same as hypoglycemia. So that fruity odor can sometimes be a clue. This is a quote from Dave Barry, one of my favorites. And I think that's pretty much it. So summary, altered mental status describes an abnormality in brain function, and causes are numerous and they can result in global changes or focal changes. Remember that AEIOU TIPS acronym to help you remember the possible causes of altered mental status. But for the most part, it's important to understand that AMS means load and go. High flow O2 for all AMS patients. You want to keep oxygen levels ideally 94 to 99%. Diabetics with altered mental status need sugar, but only if they're able to follow commands, talk, swallow, essentially that they have to have an intact gag reflex so they can protect their airway. Must treat for spinal injury with any unwitnessed onset of altered mental status until proven otherwise. And seizures, remember, scary, but usually self-limiting, and the treatment focus is preventing them from harming themselves during that seizure activity. All right, I think that's the end. Yeah, that's the end. So let me see, I'm gonna pull up the chat.
Let me talk to you there, Mary.
Yeah.
Can you hear me? That was just fantastic. And you even brought up the take homes that I would want, which is, glucose isn't going to hurt them, that, monitoring the changes over time is real important, but load and go. I love your summary there. So I appreciate that. The one, the only thing we talked about as far as the questions that people had written so far had to do with Narcan, and that's not anything we have to address. But I wonder if anyone else has any other questions.
Yeah, I don't know what your rules are about Narcan. I will tell you when we're, and that's something we use a lot because it's really not going to hurt someone if that is what's going on and it's an opioid overdose. But I think that's probably something you don't have access to on the Hill.
It's complicated. We would love to have access on the Hill, and some of the patrollers had some really good information that may allow that. In the past, there's been a problem with the economics and getting someone to pay for, several hundred patrollers to have a thing of Narcan, because unfortunately it's not cheap.
Yeah.
But anyway, hopefully we'll get around that and be able to carry it. But I have a question for you if no one else does. Does anyone have a question? They want to unmute and say something or write a chat? Or while you're thinking about that, I'll ask my question.
Yeah.
What would you say is different, or that you'd want to reinforce, or that I'm going to reinforce, about AMS and COVID.
Yeah.
What's different in the world of COVID?
That's a good question. I don't know that COVID necessarily changes altered mental status that much, except to say there may be more hypoxia. um, it may also sort of change people's comfort level as far as, with masks and things. I just encourage you, I don't know what everybody's status is as far as vaccination and whatever, but please don't be afraid of your patients. And your patient's face is a really important part of diagnosis. So get the mask off when you're trying to figure out what's going on with somebody. I would say that's a pretty big change, and kind of a lot of the time their face can be a clue to how serious what's going on. But otherwise, I don't know. I think
Well, I
we're
guess- I
certainly
guess-
seeing a lot more hypoxia.
Yeah,
So,
I guess, you answered things that I wanted you to say, but what I wanted to reinforce with all our patrollers is that, you will be in a situation where you will be face to face and you will be close contact, and you may be using an aerosolized procedure if you use oxygen. And the thing that I wanted to say is that even though you are, I believe all of you are vaccinated and you are outside, you still need to protect yourself. You still need, since we don't know the vaccination status of these patients and we can't ask, you still need to protect yourself. So you would do everything that we've talked about, be aware that if they have COVID as a cause of this, that's a separate problem. But despite whatever the causes of the AMS, please wear your mask and please wear your goggles so that you can perform your duties. Looks like we have a question, two-part question at least.
so
Yeah,
Part
I mean,
two-
just to add on to that, I completely agree. This is really part of scene safety, right? So the first thing
Yeah.
that you learn as an EMT is the scene safe? The scene isn't safe for you unless at this stage in the game, unless you've got your mask and your eye protection on.
Thank you.
That's where we're at. That's just where we're at right now. We're in a pandemic.
is.
And so
It
that
is.
is like, if there's blood, you wear gloves. If there's a person right now, you wear a mask. I mean, that's the
Well-
best way to protect yourself. It's the best thing we have.
Well, sadly, before the Delta came on the scene, we were almost dreaming of a normal ski season.
I
But
know.
Delta is so highly contagious that it's made a different ball game, and we're back to where we were before, and even then some, that we have to protect ourselves while we're performing our duties.
Yeah.
We do have
Yep.
a two-part question for you, Mary.
Yeah, so
Um,
let's see. We don't carry glucometers. Yes. Agreed. I agree. It's a fairly non-invasive, important procedure. I have no idea about why you guys don't have access to a glucometer. My guess is that there's probably a reason for it. But absolutely, I think having availability to do rapid glucose testing would be super helpful. But the other thing to remember, and this is kind of the point I was making as I'm saying, give glucose, is that it probably doesn't matter that much in that setting. It absolutely matters if, I was admitting somebody to the hospital to know whether it's high, whether it's low, how high, how low it is. If they're symptomatic at 250, I'm more concerned that this is, a type 1 DKA versus I'm much more concerned at 800 that it's more of an HHS. This is all way beyond what you need to do. You need to save their lives. That's your job. And for either high or low blood glucose, it could save their lives to give them that glucose. And so it actually probably doesn't really matter what their blood glucose is in that setting.
It's really would be nice and fun, but it's not going to change what we do.
Nope.
So I don't know why you don't have it. I suspect it's like many things when decisions are made of what's most important. That's not me making the decision. It's usually Vail. But at any rate, you don't have them, and it's not going to change what we're recommending, because whether it's high or low, if it's low, you're going to help them. If it's high, you're not going to hurt them. So I think that's one of Mary's real take-home messages. And we can talk with your admin people about whether you can get glucometers. We'd be supportive, but I don't know that's going to happen very quickly. So we are past time, Mary.
Sorry about that.
That was just great. Does anyone else have anything that they want to say? This is our last one of these lectures, the preseason. Just for all of your information, on December 6th, it'll be our first ongoing lecture during the season. It will also be broadcast and we'll have the ability to tape it. So I will get those links out to you. Those links will be different than these links. But other than that, I'm gonna let everyone, including me, go have some dinner. So I thank you again, Mary. That was really, really good. And I guess I'm gonna let everybody go home except you and Sue.
All right. Thank you so much, guys. Thank you for what you do for our community, for our patients, and have a great season.
So like I said, we'll let people sign off. It's going down quickly. You can turn the recording off, Sue.
Yep, I will.